Good afternoon, everybody. I'm James Baker. I'm an emergency room physician and an ACLS instructor since 1995. And today we are going to review the ACLS algorithm for acute stroke care. As usual, the purpose of these little video segments is to provide our students at our medical center a little preview of the material before you come to ACLS class, so that you are one step ahead of the game, so that you understand the material and you're prepared for class. It'll make learning in class that much more smoother because you know the material. Smoother learning, more enjoyable learning will make the class fun, and you know our classes are all about fun. So thanks for joining us and watching this video. The material that we are reviewing is from the standard American Heart Association published guidelines for ACLS. This is the 2010, the latest guidelines that we're taking the material from. This is the little pocket book, or same thing, this is the handbook, American Heart Association 2010 handbook produced by American Heart Association. As we always say, these American Heart Association guidelines are guidelines. So in your clinical judgment, in your clinical practice, if you come across a situation that dictates that you deviate from these guidelines, go right ahead and do so. These are simply guidelines to allow a structure for you to follow. But if a situation comes up where you need to change or do something different other than the guidelines, that's perfectly fine. Go ahead and do it. Rely on your own clinical judgment and decision making. Okay, so today we're talking about acute stroke care and the acute stroke algorithm. We're going to give you a case here, and typically when we start out with cases for Megacode in our classes, if we start you out with a patient that's awake and alert and talking, we want you to ask for 4 basic things at the very start of the case: O2, IV, cardiac monitors, and vital signs. Okay? IV, O2 monitor, vital signs. IV, O2 monitor, vital signs. You ask for those things and it will start the case rolling. We'll provide you with information, data that you can use so that you know what algorithm you're in and follow along the algorithm. So our patient, we're going to start out with our patient. We'll call him Mr. Jones. He's a 70-year-old patient. He comes in complaining of feeling weak. And that's all he tells us, he's feeling weak. So we're going to put him on O2, get an IV in, put him on our monitors, and get some vital signs started. So we're going to pretend to hook him up, and our monitor shows what looks like an irregular rhythm, narrow QRS complex, rate is in the 90s, 100, kind of fluctuates, but we don't see any P waves, and that irregularity shows us or tells us that this is AFib, or atrial fibrillation, that we're dealing with. So we might want to confirm with the patient, do you have a history of atrial fibrillation? And he'll say, yes, I do, but I never take my medication. I never take my Coumadin or my anticoagulants. So this is one clue, because AFib, patients can be predisposed to forming clots and throwing clots, which can produce stroke. So if we reassess our patient and ask a few other questions, a little bit more in detail, well, sir, show me your face and smile for me. And if he's got a drooped face, that's one indicator of a possible stroke. If we ask him to speak for us, is he speaking clearly? Can he recite back to us? You can't teach an old dog new tricks, and if he's slurring his words and can't get the words out, that's a second basic indicator that he could be having a stroke. Third thing is motor weakness. If we ask him to put his outstretched arms out, and if he's weak on one side and all of this is new, that's a third indicator that he's possibly having a stroke. The stroke scale that the American Heart Association likes to use is the Cincinnati stroke scale, and it will test those 3 things I just went over: facial droop, slurred speech, and weakness, one arm or one side of the body. If a patient has only one of those 3 signs, the chances that he's having a stroke is 72%. Okay? So it's high likelihood that this patient with AFib has thrown a clot and they've got a stroke. The next question we need to ask is, when did these symptoms start? What is the onset of symptoms? Because we're looking for a time window where we can treat this patient and reverse his stroke. For typical strokes, it's 3 hours or less. For most patients, or many patients, that time window has now been expanded to 4.5 hours or less. So if he meets that time window, we can possibly treat him with the fibrinolytic or thrombolytic therapy, the medication called TPA. All right, so let's go through our poster, our algorithm produced by the American Heart Association. And starting at the top, identify signs and symptoms of possible stroke. So that's going to be our Cincinnati pre-hospital stroke scale of slurred speech, facial droop, or one-sided weakness. The green box represents EMS or pre-hospital care, so obviously support ABCs, give oxygen if the oxygen is less than 94%, do our stroke assessment, establish time of onset of symptoms, alert the hospital, triage to a stroke center, and check an Acute check as well. Check the sugar level, because patients that are diabetic, if they have a low blood sugar, sometimes that can masquerade or show us signs that could be mistaken for stroke. So check for hypoglycemia, and if you find it, give sugar and see if those symptoms go away. Another point I want to make is triage to stroke center. So a typical situation would be if the patient is going to go to a hospital and their CT scanner is down or malfunctioning, then the correct maneuver by the paramedics would be to divert that patient to another hospital that has a CT scanner capable of performing and doing a CT scan on the stroke patient. Okay, so that's what they mean by triage to a stroke center or a hospital that has CT capability. We go down to the next box. The patient arrives to the emergency room. Check our ABCs, our vital signs, do our O2 IV monitors, do an Acute check, perform our quick neurologic screening assessment, which is our Cincinnati stroke scale, alert our stroke team, and get our patient to CT scan or MRI fast. Okay? And once we get our patient to CT and back, we should have a reading of 30 minutes or less for that CT scan. Okay? Perform our neurologic assessment by stroke team or designation, review the history, review the time of onset of symptoms, do our NIH-SS scale, and get our CT scan results back. In the first few hours after an acute stroke, our CT scan should be normal. CTs do not show any abnormality in the first few hours of stroke. So if there is an abnormal reading or blood or hemorrhage, like this branch of the algorithm shows us, then our patient is disqualified from meeting the stroke criteria of fibrinolytic or thrombolytic therapy. If our CT scan does not show hemorrhage and is otherwise normal, then our patient has an acute ischemic stroke and we need to consider fibrinolytic therapy. So we need to go through our book, our checklist, inclusion, exclusion criteria, make sure our patient meets those, and following our repeat neurologic exams. If our symptoms improve suddenly and go back to normal, then we would term this patient a TIA, or transient ischemic attack, and we would not give this patient fibrinolytic therapy. If our patient remains a candidate for fibrinolytic therapy, then we've got to review the risk and benefits with the patient and family of giving fibrinolytic therapy. Our fibrinolytic therapy is going to be TPA or RTPA, and if we do give TPA, the patient is not to have any anticoagulants or antiplatelet treatment for the next 24 hours. Now, sometimes patients will come in and they'll say, well, I've been on aspirin. Is that okay? Am I still a candidate to give TPA? And the answer is yes. You can certainly still give TPA to those patients. Just do not continue to give them aspirin or any kind of blood thinners after you've given them the TPA. Okay? Few other things, tips to go through. Remember the difference between ischemic stroke and hemorrhagic stroke as it listed on the poster. These patients that are candidates for TPA fibrinolytic therapy, they should be showing ischemic stroke, meaning the blood vessel got blocked or narrowed and there's no blood flow, but there is no hemorrhage, there is no bleeding in the brain. There are 8 Ds of stroke care. You don't need to know all the 8 Ds, just remember that they do exist, from dispatch to detection to drug to door to disposition. Remember, fibrinolytic therapy can be given within 3 hours of the onset of symptoms for most patients, and that window is expanded to 4.5 hours for many patients. Which patients, oftentimes we're asked, which patients does the 4.5 hour time window not apply to? Which patients cannot get fibrinolytic therapy if they're in the 3 hour to 4.5 hour time range? And the exclusion criteria for those patients are any patient older than 80 years old, any patient that has a severe stroke scale, an NIHSS scale of 25 or greater, if a patient has been taking any kind of oral anticoagulant, irregardless of their INR reading, or if the patient has had a history of both diabetes and a prior ischemic stroke in the past. Those 4 criteria remove the patient from consideration of getting TPA. Otherwise, all the patients that meet the criteria in our checkbook should be able to get TPA therapy. Okay? Back to supplying oxygen. Patients that have a pulse ox of greater than 94 should not get supplemental oxygen, so no O2 for those patients. Always remember to do an Acute check to make sure you rule out hypoglycemia in these patients, which low blood sugar can mask strokes or misleadingly cause stroke symptoms in patients. Make sure you use your Cincinnati pre-hospital scale of facial droop, slurred speech, or one-sided motor weakness. Make sure you are constantly monitoring the ABCs on these patients: airway, breathing, circulation, IVs, monitors, vital signs. And to our vital signs, if our patient is going to be a candidate for fibrinolytic therapy, they need to have a blood pressure of less than 185 over 110. So if the instructor tells you your patient's blood pressure is 190 over 120, you've got to lower that blood pressure under 185 over 110 before you give them the fibrinolytic thrombolytic TPA therapy. And you can use labetalol, you can use hydralazine, you can even do some nitroglycerin in order to lower their blood pressure under 185 over 110 so that they're a fibrinolytic candidate. Sometimes we're asked, well, what's the risk of giving TPA? Certainly that's a super blood thinner. Is there some risk of bleeding? And the answer is yes. And the main risk is the risk of cerebral hemorrhage, bleeding in the brain. That risk is about 5%. So you need to make sure that the patient and their family are aware. Yes, probably 30% of the time we can have success in reversing a stroke and improving the signs and symptoms of stroke, but it comes with a 5% risk of inducing cerebral hemorrhage. So you have to make sure you know that number and make sure the patient and their family are aware. We talked about repeating neurologic outcomes, repeating neurologic exams to make sure the patient isn't deteriorating or rapidly improving, because if they rapidly improve, you may not want to give the fibrinolytic therapy and induce that risk. And then finally, make sure if EMS pre-hospital is calling, make sure your CT scan is working. If it's not, then the answer is to tell them to divert to a stroke center or a hospital that has CT scan capability. And then finally, you want to make sure, this is kind of a post-resuscitation after you give the fibrinolytic therapy, you want to make sure you ask and do a final rundown of the ABCs, make sure your vital signs are stable, make sure you get a post-case EKG, X-ray, lab work, everything you can think of at the end of the case. Just make sure you ask for the case and ask for the results. Make sure there's no other information you need to act on. And with that, I think that concludes this segment of acute coronary syndromes review for our ACLS classes at our medical center. And you know who you are. So thank you for watching. Make sure you watch the other video segments of ACLS class review so that you come to class prepared and ready to go. Thanks for watching and have a good day.